that's my name. It's Srirekha Vadasseri. I was trained overseas in India as an anaesthetist, and after migrating to Australia, I have trained in psychiatry and subsequently in pain medicine. I've been working in pain medicine for the past 7 years, and now I exclusively work privately at the Melbourne Pain Group as a psychiatrist and pain specialist. Now, how many of you here are psychologists? Okay, and the others, what fields are you from? Is it
Counseling.
counseling? Okay, and social work?
Social, yeah.
Social work, yeah. Any other fields here?
Counseling and
OT and
counseling and vet science, which is very unusual.
vet science.
Yeah. and
Wow!
There was some
Congratulations!
pain stuff in there as well.
Oh wow! I think probably that needs a lot of empathy.
Yeah.
So I think you're in the perfect field.
Thank you.
Wow, that's nice. Okay. So any other specialties, allied health? Nursing. Oh wow. Wow, thank you for coming. So I suppose, most of you here must work with borderline personality disorder? Yeah? Anyone who doesn't work with borderline personality disorder? Yeah, I thought that's a better question because I think all of you probably do. So it's not new to you, I don't need to tell you anything about it, but borderline personality disorder basically I think is the most commonly diagnosed of all personality disorders, and it's characterized by unstable mood, identity, interpersonal difficulties and self-harm behaviors. And the prevalence is about 1% in the community. There's one person I recognize. She's a psychologist who works with me at the Victorian Rehabilitation Center. Thank you. Hi. So, how many of you work with patients with chronic pain here? Okay. At least 50%, okay. So, the International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So it's an experience with sensory, cognitive and emotional components. And what we all must remember is, of course, pain is always subjective. So, for example, I could be standing right here and saying that I've really got a bad back pain, and on a scale of 0 to 10, it's about 5 out of 10. And probably people can look at me and say, oh, not really, you're joking. But that's the whole point about pain. Pain is a subjective symptom, and it's not for anyone else to judge what another person's pain is. Now, the field we mainly deal with is chronic pain, because acute pain, those are the, where it's less than 3 months, it's usually related to a trauma or an injury or something. But when the pain has lasted beyond the time expected for healing, following surgery, trauma or other condition, and usually arbitrarily it's about 3 months. So when the pain persists beyond 3 months, then it's called chronic pain. And usually acute pain can transition into chronic pain if it's untreated or poorly treated, or the longer the pain remains untreated, it's likely to be chronic. So basically what happens is there are changes that occur within the nervous system which makes the body more sensitive to pain, and after some time pain itself becomes a disorder. So therefore, timely and effective treatment of acute pain is essential to prevent transition into chronic pain. Now, personality and chronic pain is, as you can imagine, it's a very important intersection between the two. And pain itself is more than just a sensation indicating tissue damage. It is a physical and emotional experience. And with personality, the personality disorder can predate the pain condition, or personality changes can be secondary to chronic pain. Now, coming to the chronic pain subpopulation itself, personality disorder in chronic pain is higher than those found in general population. and the prevalence ranges from 30 to 60%. So typically, personality disorders are considered to predate the onset of injury and may complicate the course of the pain condition. And in this patient population, there's a high level of prevalence of cluster B, the dramatic emotional personality disorders in chronic pain population. Now, there are a few studies that have studied, the link between chronic pain and personality disorders. One study reported that 51% of patients with chronic pain met criteria for one personality disorder, and 30% met criteria for more than one. Another study found that 60% of persons with chronic pain met diagnostic criteria for a personality disorder, in contrast to research findings that only 21% of patients with acute low back pain met the diagnostic criteria. So obviously in chronic pain patients, the personality disorder is certainly of a higher prevalence. I'm going to just highlight a case history of a patient I've seen, just to highlight the importance of emotional issues leading to a chronic pain condition. I'm sorry, in between I'm going to be sipping some water. I hope that's okay. So this lady, Clara, it's a pseudonym. She was a 70-year-old single mother, ex-nurse by profession, and she complained of headaches since 2 years. Now, the GP referred her to a pain specialist when the headache did not remit at all. And the pain specialist tried several analgesic medications, but she poorly responded to the medications. Ultimately, the pain specialist decided to trial an occipital nerve stimulation. So, in one of those sessions when he was actually explaining to her about this procedure, she became very teary and emotional. So that's when she was referred to me. Now, when I took the history, she reported that about 2 years ago, what happened is a good friend of hers was going away to Adelaide. Her husband had had just a hip surgery. So during that time, 1 week or so, she was away. So she requested my patient Clara to look after the husband while she was away. Now, on one of those evenings when she actually went, the husband, the friend's husband, actually sexually assaulted her. And this was extremely traumatic for this woman because even though he had just had a hip surgery, he tried to barricade her within the house, and she literally had to somehow open the door and run out from there. Now, following this, the 30-year friendship that she had with her friend, she lost that. And she had a regular philosophy group of friends that she met. So 2 months later, she couldn't keep this within herself. She actually revealed it to the philosophy group. But following that, she had symptoms of post-traumatic stress disorder and major depression and intense feeling of guilt about what had happened. Now, so after I started seeing her, I basically managed her with some antidepressants and psychotherapy, and actually her headaches resolved. So what I'm trying to say is sometimes patients go with pain complaints to pain specialists, and if we don't have that psychiatric, psychological bend where we are looking at the person as a whole and not just at the physical pain symptom, it's very easy to use more and more medications, stronger medications and interventional procedures. Now, coming to the commonalities between pain, chronic pain, and borderline personality disorder. Both are obviously very chronic conditions, very complex, and they usually have their origins in physical or emotional trauma. As in, pain is usually, starting point might be a physical trauma. Usually with borderline it will be some kind of emotional, I guess it's more an emotional condition, whereas chronic pain is more about physical expression of pain. So in terms of trauma, they could either have physical or psychological trauma, and it could be either a recent event or something that happened way back in the childhood. Doesn't matter what, but both of them have significant functional impairment in terms of relationships, in terms of employments and finances, and they certainly lose out on a lot. They have repeated contacts with the health professionals and multiple medical comorbidities and multiple psychiatric comorbidities. And substance use disorders again are common in both these conditions. And they both can have depression, and unfortunately both in borderline personality disorder and the chronic pain condition, the depression itself can be quite treatment resistant because the basic pathology, whether it's of the chronic physical pain or the emotional pain, seems to maintain the depression. And medications don't work well, but unfortunately some patients, we can't say all the patients, they seem to focus on a chemical fix for their problems. And psychiatric treatments do work, and I think the focus should be psychological treatment, but it's not accessible for everybody, and the resources are quite limited in this area. And of course, there are huge countertransference issues. I think I've got a slide later about it. And they are extremely challenging to treat. And in fact, one of the reasons I actually took pain medicine was when I was training in psychiatry, my consultant usually had a chronic pain patient who used to come and see him regularly. And every now and then, the consultant would ask me to see the chronic pain patient, and I would be like, oh no. Because I just did not know what to do with this patient. I used to feel sorry for him, and but I just did not have the words to soothe the person. And I must say, during the entire psychiatry training that I had, I found chronic pain the most challenging group of patients. And I think for some reason I gravitated into that, as we do sometimes. And of course, these patients need long-term treatment, and they're quite challenging to treat. And the carer burden is quite immense with these patients because in fact, it's not just the patient who is suffering, it's the entire family, and the carers take a lot of burden of it. And apart from the carers, of course, there's a huge stress and burnout in staff and clinicians. But for those who work and who continue to work and look forward to working, it can be quite rewarding to work with this group of patients. Apart from all the other points that I mentioned, I think one of the most important commonality between pain and borderline personality disorder is the high rate of suicide. I think amongst all the, maybe Satya might correct me if I'm saying the wrong thing, but amongst all the, psychiatric disorders, borderline personality disorder seem to have the highest rate of suicide. And suicidal act is an attempt to escape intolerable suffering. And there is a quote which I actually like, which says, "Suicide is not so much a movement towards death as it is a movement away from intolerable emotion, unendurable pain, and unacceptable anguish." And I think this is what we need to remember. It's not that they want to die, it's just that they find the emotional or physical pain that they're going through so unbearable that they just want out from it. And I think similarly, just as borderline personality disorder patients, chronic pain patients they almost constantly have suicidal ideation, suicidal thoughts. So in fact, on a daily basis, I'm sure people working with pain will see almost every day we have some patients who, every time they come, they're just saying, I want to give up, what's the point? So it can be quite challenging to manage that suicidality. As you can see, there are 3 slides for commonalities, but just a very few for differences. I guess the main difference is in patients with borderline personality disorder, you may have childhood trauma and sexual abuse. Not that it's not there with chronic pain. In fact, sometimes just childhood sexual abuse and trauma can predispose patients or people later on to actually develop chronic pain conditions. And age, of course, with the normal onset of age of borderline personality, it's more the mid to late teens. And of course, there is a group of patients who do manifest borderline personality disorder later in life. But with chronic pain, it can be across the board really. But the other thing which again we see with chronic pain patients are that most of these patients have either been injured at work or have had a road traffic accident or some kind of accident that way. So there is that huge medical, legal and compensation system that comes into play. So then it becomes extremely difficult to actually try and improve a person who has got either chronic pain or some kind of disability, while the whole system actually focuses on maintaining the disability. So it becomes very challenging as clinicians to try and help them move. So that adds a huge layer of complexity to an already complex disorder. Now, a comorbidity in borderline personality disorder patients. I think people who work with BPD would know that comorbidity is the norm rather than the exception with BPD patients. And apparently only 5% are present in the pure form. So there can be various comorbidities. The other personality disorders can account for 90%. The anxiety disorders such as PTSD, OCD can be 89%. Depression can be quite high, 75%. And of course, substance abuse, bipolar disorder, psychosis, eating disorders is quite high. And of course, they can have other medical illnesses, dissociative disorders, ADHD and gambling. Now with pain patients, the psychological disorders may predate, may coincide or emerge as a consequence of chronic pain. And the comorbidity itself can contribute to pain or exacerbate and maintain pain. And again, this is very important in the compensation system, where they always want to know, did the psychological comorbidity, was it there prior to the compensable issue, or did it come later on, or did it happen at the same time? And I guess we spend a lot of time trying to tease out whether it came before, during or after. Now with pain, there is a significant psychiatric comorbidity, and literally all the diagnoses in DSM-5 can be there with chronic pain patients. So right from, adjustment disorder, I think anybody with chronic pain, they would definitely have at least the diagnosis of adjustment disorder. Of course, they can have major depression, anxiety disorders, post-traumatic stress disorder, several forms of psychosis, and particularly with psychosis, it's not that they might just have a psychotic illness, but also the medications that are prescribed, the strong analgesic medications, and even ketamine infusion that's given for chronic pain on its own can cause psychosis in some predisposed individuals. And of course, substance abuse and dependence. And the substance abuse and dependence may not be just illicit substances, it might be actually prescribed medications that they overuse, or a lot of our chronic pain patients, they just go to the counter and just buy. Panadols are like lollies, I take 20 Panadol and still it does nothing to the pain. But the thing is, it is important to actually find out that they are using all these substances. And sometimes we think that that is it, it's what they have prescribed is what they're taking, but it's important to say, apart from all this that's prescribed, what else are you taking? And then there'll be a whole list of other things that they are still using. Of course, we've spoken about personality disorders being comorbid with pain. Sleep disorders, patients with chronic pain have a huge issue with sleep. They have difficulty falling asleep. Even if they fall asleep, some slight movement and they wake up. Or they just cannot get a comfortable position. Or they wake up and then they just cannot go back to sleep. And sexual dysfunction, again, a huge issue for patients with chronic pain, and also can be a cause for significant marital disharmony. And unless we ask about it, they may never come forth with it. And of course, factitious disorder and malingering is something that we have to think about with chronic pain patients, and particularly with relevant to the compensation system. Now, coming to borderline personality disorder presentations in the context of chronic pain, now, when do you actually suspect that a patient has borderline personality disorder? So you got a chronic pain patient, but then sometimes the they can have chronic physical pain after a very minor trauma or trauma that does not fully explain chronic pain. And that's when you have to think, does this person actually have a personality disorder? And sometimes patients who are having borderline personality or some other personality disorder might feel that physical pain is more acceptable than emotional pain. And it might also be their way of seeking validation for their distress. Now, the prevalence of BPD in patients with chronic pain, I think I mentioned this before, it is significantly greater than in the general population. And the usual, like the average is about 30%. And it is linked to the increased pain severity and poorer coping with pain. And patients with BPD use non-suicidal self-injury as a tool, and it's used in an effort to decrease emotional pain and induce calm, which I think all of us are familiar with. Now, those who have BPD often report absence of pain and relief of emotional pain when engaging in self-harm, which may actually reinforce a tendency to continue self-harming as a way of coping. I'm sure all of us know patients who self-harm and actually say that they felt better when they self-harmed. Now, pain itself in BPD patients is very interesting because pain threshold is elevated in patients with BPD. And the pain processing itself is abnormal in BPD patients. Now, the altered processing, so basically the alteration is there's a difference in the processing of nociceptive stimuli in the prefrontal and the limbic brain areas. 70 to 80% of BPD patients generally engage in self-injury. Now, what is the function of self-harm in these patients? Self-injury in BPD patients is an emotional regulation strategy. What happens is when they have physical pain, it leads to decreased stress levels and neural deactivation of amygdala. So the functional connectivity of the amygdala with the superior frontal gyrus is normalized after incision in BPD patients. And apart from these, so in a sense, the amygdala, which is very active in these patients, when they harm themselves, the pain causes a kind of calming effect. There's a deactivation of the amygdala, and that's why they feel calm. Apart from that, there is analgesic effect of self-harming repeatedly. This is thought to stimulate the endogenous opioids, and that is why they feel relief when they cut themselves. So self-harming in BPD may serve as an essential function in relieving emotional pain. This is just a slide to show whether they have BPD or chronic pain. I think basically within all that they have got fear, they're depressed, they're anxious, they're frustrated, they're furious, and they're basically saying, help, help me, help me. And of course they can have a lot of negative cognitions about what they're going through. Now, the pain paradox in BPD patients, this is something I want to really highlight. The relationship between pain, self-injury is very complex in BPD patients. BPD patients basically have a biological predisposition to greater emotional pain. But depending on the context of pain, they could be highly pain tolerant as well as highly pain intolerant. So they could be either way, depending on the context. Now, the overlap of emotional and physical pain in BPD patients. We've spoken that BPD is, of course, commonly comorbid with chronic pain, and they do indulge in chronic self-destructive behavior. Presence of BPD itself complicates the treatment course of chronic pain. because of their innate difficulties with self-regulation of pain. Sorry, did I do something?
No, automatic system.
Oh, I see, okay. Sorry, I meant to mention before, if any of you have any specific doubt and you want to stop me, interrupt me, please feel free. So, the BPD predisposes individuals to higher pain tolerance in the face of acute and self-inflicted pain, but lower pain tolerance and greater pain severity and poorer coping in response to chronic pain. So this is where the paradox is. They are able to tolerate, the acute pain, they can tolerate it, but chronic pain, they can't tolerate it. Now, the reason for this lower pain tolerance for chronic pain in BPD patients is, one, it could be the feelings of helplessness and rejection, often inherent in the process of seeking treatment for chronic pain. Clinicians who are unfamiliar with chronic pain may respond in a way that reactivates the experience of invalidation. Particularly with BPD patients, if reports of physical pain and distress are dismissed, it is likely to trigger feelings of rejection and abandonment. And because this group of patients particularly are vulnerable to, invalidation. So, and having overwhelmingly painful emotions may worsen the pain and decrease the ability to manage it. So that is why BPD patients actually don't tolerate chronic pain that well, whereas they can tolerate acute pain.
So just on that, why is it that people with BPD have a higher pain threshold?
I guess it's when we say threshold, no, they have a higher pain threshold for acute pain, not for chronic pain. Yeah. So what they've done is they have done experiments where a group of patients who did not have BPD and a group of patients who had BPD were given the same painful stimulus. The patients with BPD are able to tolerate the acute pain. They can tolerate higher intensity of the pain stimulus that was given. Whereas the normal patients, normal people who don't have BPD, say crying out pain much earlier than BPD patients. So it is for those reasons, because in them, because the amygdala is hyperactive, when they actually cut themselves or have some painful stimulus, it seems to, in a sense, calm the amygdala, and the endogenous opioids, of course, are released. So that is why they have a higher acute pain tolerance. But that is not so with the pain that is ongoing, then that they don't have that effect. It's only with the acute pain,
Thank you.
Particularly healthcare providers who are not well informed about pain can leave pain sufferers, particularly with BPD, without a plan for pain management and vulnerable to feeling unheard and invalidated. And ongoing and intense stress of chronic pain can overwhelm coping resources and diminish the ability to cope with either pain or the social, medical, and interpersonal challenges that accompany it. So, patients with BPD, as such, find it difficult to cope with, any kind of changes, but when they also have chronic pain, they have to negotiate so many more, different healthcare professionals who may or may not validate their pain. So it becomes much more complex the more healthcare providers they're accessing, and of course, not to mention the effect it has on their carer, the social effects, and so basically a lot more interpersonal challenges for BPD patients with chronic pain. In BPD patients, the pain symptoms may function also as an interpersonal means of eliciting caring response from others. And again, some patients might feel that it's better to say that I've got pain and get the nurture and caring, rather than say, I just don't know how to describe this emotional pain. So sometimes expressing it as physical pain might be easier for them. Which brings to a patient of mine, and I want to highlight this patient because she had a lot of issues, and as I'll present. So Bonnie is a 33-year-old mother living with a husband and 4-year-old daughter. She was the youngest of 3 children. Her mother was emotionally abusive towards her, and when she was 12 years old, her parents divorced. She stayed with her mother, but she was very close to her father. Now, when she was about 16 years of age, and this actually happened when she was walking home alone from school, she had a horrific sexual abuse, wherein her perineum was torn, her spleen was ruptured, and she needed admission to the ICU. Following the discharge and then on, she commenced smoking cannabis, using alcohol, and she developed symptoms of borderline personality disorder. She also started cutting herself to emotionally regulate. When she was 18 years old, she was actually called to court to give evidence against this person. This was extremely traumatic for her, and she felt that no one believed her. So, following this, she actually developed major depression as well. She did not get any psychiatric help. When she was 24 years old, she attempted a serious suicide by crashing her car into a tree. She was in coma for 10 days with closed head injury, lacerated liver, punctured lung, and multiple fractures. She had post-traumatic amnesia, and she couldn't recall that she had crashed a car. So the head injury was significant, but when she was told that she actually had committed suicide, she could not believe it until she saw her own suicide note. And that's when she realized that she had actually attempted to commit suicide. Now, following this, she developed widespread pain. Now, widespread pain in these conditions, and we do see a lot of patients who maybe after an accident developed widespread pain, and they go on to get a diagnosis of fibromyalgia. So, in patients who have had difficulties in their childhood, traumatic experiences in their childhood, seem to be prone to develop widespread pain, such as fibromyalgia. So, in case of Bonnie, she developed widespread pain, post-traumatic stress disorder, obsessive-compulsive disorder. She had obsessive doubts and worries, ordering and checking compulsions. And since admission into the ICU, she was referred to pain specialist, and at that time she had some input from mental health clinicians. She was treated with opioid medications, antidepressants, and was also commenced on lithium since then. 2 years later, at 26 years of age, she got married, and 3 years later, when she was 29 years, she became pregnant and had a daughter, and she developed postnatal depression. Her daughter had to be in the neonatal ICU to withdraw off the opioids. Subsequently, at 30 years, when her child was about 1 year old, she became suicidal and had thoughts of slashing her neck. She didn't do anything at that time, but at 31 years, she attempted suicide by taking an overdose of 400 tablets of lithium, which is a massive amount of lithium. I mean, people might be on anywhere from 2 to 6, maximum 8 tablets. So 400 tablets is a very, very huge dose of lithium. So what she actually did is, she went away from home, sat in an isolated car park, and she had a very close relationship with her father. Her father was overseas at the time, and she sent him a message on social media, basically, goodbye, I had enough of this life and I want to end my life. Now her father, who was somewhere in Southeast Asia, alerted the police here in Victoria, and they traced where her phone was, and that's how she was found. Lucky for her. Or she reported, following this suicidal attempt, that the physical pain was what got to her. Because after a car crash, she had intense physical pain. So at this point, it was not the emotional pain. It was the physical pain, and she felt that she was a burden on her family. Her husband, extremely supportive man, so he was looking after the 1-year-old baby or 2-year-old baby along with his parents and his parents' support. So she felt like a burden. But luckily for her, after this, she was linked to the community mental health services, and she had a psychologist seeing her on a weekly basis. This was 2 years ago. I got involved in her care because she came into the hospital to get a ketamine infusion for her pain. I must say she's doing extremely well. Emotionally, despite all that she's gone through, she is a picture of strength today. And she says, you know what, in terms of my BPD, I'm okay now. I've stopped cutting, I don't cut. It's just the physical pain sometimes that just gets to me. But luckily for her, she has responded well to ketamine, so hopefully from now on her trajectory will change as well. But I wanted to present this case to highlight the interface between chronic physical pain and in a patient who has already got borderline personality disorder. And I sometimes, or actually quite often, ask my patients, particularly when they've got personality disorder, I tend to ask them, is your physical pain worse or is your emotional pain worse? And sometimes they say, you know what, it's kind of 50-50. But sometimes they actually articulate and say, you know what, it's the physical pain that gets to me. Or sometimes they say, you know, physical pain I can manage, it's the emotional pain. That's what I can't handle. So it's a useful question to ask. And I guess in a sense it also dictates our treatment. We need to know whether to focus on the physical pain management more or the emotional pain management. Now, I mentioned before about countertransference, and of course there are various pejorative terms that are used for patients with borderline personality disorder and also with chronic pain. So whether it's attention seekers, manipulators, pretenders, chronic, never get better, she is a PD or BPD, so-and-so is a pain. And it's the typical heart sink patients. You know, when you see this patient, oh, can I help them? I feel lost, I don't think I can help this person. They're basically frequent flyers to the healthcare system. So then now we come to the management. I'm not sure if you want a break now for a few minutes. I don't think I have many more slides. Like Rita said, I don't think I'm going to be presenting for much longer. But if you want to have a break, stretch your leg, have a coffee or something, I'm fine with that. Okay? Sure. There's only one word on this slide, but it's the most important word. I think both for BPD patients and chronic pain patients. Validation, validation, validation. They need to know that people treating them understand that they are going through pain, you know. It's not for us to judge another person's pain, they are going through pain. And if there's one thing we can do, if we can just validate their pain, I think we have actually won them over in the treatment. Because at the end of the day, with these patients who can be quite difficult and challenging, the most important thing is to win them over to our side so that then we are together working with them. If you're going to be, you know, they're going to be there saying they've got pain and we're saying, no, you don't have pain, you're never going to be able to help them. I've just written there examples of invalidation, and I'm sure all of you have had experiences where your patients have come back and told, the common thing we hear is, particularly when patients go to say independent medical examination, or doctors or treaters, they see one off, they're usually told the pain is in your head, you're imagining it, you couldn't have this kind of pain. And I even had a patient who was asked by a doctor, how much pain do you have on a scale of 10 to 10? On a scale of 0 to 10. 0 being the no pain and 10 being the highest pain imaginable. And this patient at that point said 10 out of 10. And the doctor is supposed to have turned around and said, how could you be having 10 out of 10 pain? If you had 10 out of 10 pain, you would be comatose. And another patient was told by this male doctor, you couldn't be having 10 out of 10 pain. That's what happens when you deliver a baby. So this patient, lady patient, cheekily turned around and asked, have you ever delivered a baby? So I think it's not for us to judge another person's pain. You know, people express pain differently. Some people might just lie down and they say they've got 10 out of 10 pain without making a noise, whereas other people might just have 2 out of 10 pain, but they might just be, you know, screaming and yelling for help. So how one expresses pain is based on several things. The way you've been brought up, the kind of expression in your family, in your community, in your culture, and also the kind of distress and in what context it is happening, and if there is other comorbidities. Now, in terms of validation, the other thing I wanted to highlight is sometimes patients who have pain, they're constantly saying, you know, but I've got this pain, I've had this investigation and nothing is showing up, nothing is showing up. And suddenly, sometimes they'll just come and say, hey doc, I've got good news for you. And I wonder, what's the good news? You know, you're happy when they're sharing a good news. And they'll say, you know what, I had that MRI last week. The MRI shows a disc bulge and it's actually pressing on the nerve. So it's not that they're happy that the MRI showed that there's a disc bulge or that it's pressing on the nerve and it's causing the pain. It's that at last there's some validation for my pain. I've been telling for the last 2-3 years I've got this pain. Nobody bothered to listen to me, and you know, nobody understood that I was having pain. And now the investigation is showing. So the investigation has provided them the validation which maybe many times the clinicians haven't given them, you know. So coming back to validation is extremely important for both BPD, patients who go through emotional pain, and patients who go with experience chronic physical pain. Which comes to, why do patients actually amplify the expression of pain? So it might be actually a manifestation of a psychological distress, or it could be a function of somatic amplification, which means they might want to enlist support of others to tell them, you know, I am actually in a lot of pain, so please can you help me? Or it might actually be a way of distancing others, or allowing expression of discontent or anger or avoidance of interpersonal conflicts. Or sometimes it might be avoidance of unpleasant tasks and responsibility. You know, when someone says they've got pain and they're lying down, then maybe the wife is not going to ask them to mow the lawn. So there can be avoidance of unpleasant tasks and responsibilities. But it also can serve to mask other psychological symptoms because of stigma of people feel that, you know, when they say physical pain, it's more acceptable than saying something else, that I'm going through depression, so they feel that physical pain is more acceptable. It can serve to mask other psychological symptoms, so stigma of a psychiatric disorder imply that something about their character. So that maybe also some patients might actually not express as much pain because they feel that they have to be stoic and, you know, they have to be man enough to handle the pain, they can't be expressing pain. But of course, so that is sometimes people can underplay the pain. Sometimes, of course, patients do feel that somatic concerns are taken more seriously than emotional factors, and they can amplify pain. They say crying babies get milk, so whoever screams loudest gets the attention. I think I have highlighted this. Acknowledge that the pain is real no matter what the underlying cause. Pain is pain is pain. Because going back to any time, if you have a person sitting in front of you and they're saying that their pain is quite significant and it's 12 out of 10 or 14 out of 10, sometimes they say 20 out of 10, we don't question it, because going back to the International Association Study of Pain, the definition for pain, it is a subjective symptom. But when someone says the pain is 14 out of 10 or 20 out of 10, what we need to know is, why is this person expressing this amount of pain? What is going on within them? That is what we need to get to. Pain is inevitable, suffering is optional, and that is something I think we tend to teach our chronic pain patients, that you can have pain, but to suffer is a choice. Now, therapy for BPD, I think you all know the various therapies that are available for BPD. So there's DBT, MBT, transference-focused psychotherapy, and schema-focused therapy. With patients with pain, the main therapies we use is cognitive behavioral therapy, because invariably they have a lot of negative cognitions, they do less and less, they keep to themselves. And mindfulness is extremely useful for patients with chronic pain and management of pain, and acceptance and commitment therapy. Now, the outcome studies of patients with pain and BPD are generally lacking. So we don't have many studies with BPD and chronic pain. But the overall management of management approach to these patients, so patients with BPD and chronic pain, it should be conservative treatment. And particularly, if they are given medications, this has to be closely monitored, specifically the stronger analgesics and such as opioids. Physical pain and psychological pain has to be treated simultaneously, and I think this is extremely important. We see, particularly in our field, in chronic pain, we tend to see that patients with chronic pain are treated by maybe anaesthetists or rehabilitation physicians, but where they only look at the physical pain. But it's important to look at the person as a whole, and I think if everybody with physical pain has to have a psychological assessment, and invariably at least they have adjustment disorder. And in terms of managing and coping with the pain, the psychological treatment has to go side by side with treating the physical pain. And of course, with these patients, one has to anticipate a chronic course without maybe full resolution of the pain symptoms. Overall, patients with this type of comorbidity tend to be very challenging to manage, as we all know. Rita, I think I've finished.
Okay.
I've got one last slide, so I'll just finish this slide. So basically, take-home message, emotional pain or distress can be expressed as physical pain. Validation of a patient's pain helps reduce their preoccupation and expression of pain complaint. Psychological interventions can be very helpful. Treatment of coexisting psychiatric disorders is an essential component of pain management. And the aim is to move patient to self-managing their pain. I think with that I finish my presentation. Thank you so much for your attention.